and enthusiasm stayed almost with us. So just a brief summary, you see already there, you got a lot of fellowship, and his main passion is to improve the ankle, and his also passion to to care of athletes that of course have to go back quickly and best possible situation to their practice. He got the family medicine, the medical degree in license in 2003 in Cairo at the Ain Shams University. And then he also had the residency program in the same university and the teaching hospital El Haled, and I believe large volume center up to 2009. And then a number of fellowships, as you've seen there, in Dubai, Rashid, but also in Switzerland, in Germany, in South Africa, in Johannesburg, and in Barcelona, Spain. And in terms of practice, mainly all these practices have been from December 2010 to December 2020 when he joined FUH in the Rashid Hospital. Again, it's a large volume center. And we also had some sharing of the news on some athletes that have been treated, and they were very grateful for his expertise. And I believe today he's talking about something that is probably related to the go back quick to the practice. So it's a mini-invasive procedure. All the surgeons are doing mini-invasive, so to scale less the people, but maybe to have a great job with the less care and back to the activity very soon. So, Dr. Khalifa, pleased to welcome you to the podium. It's your time. You have several recordings in progress on YouTube, LinkedIn. So
thank you, Dr. Vito, and I appreciate the ATA for inviting me. So why I've chosen the minimal invasive technique? Now the era of the worldwide to go through minimal invasive for the medical, surgical, even I guess in the technology. Now they are trying to minimize all the technology and the procedures. What do you think about the minimal invasive? Why we are choosing the minimal invasive? Do you think because of the cosmetic? This is one of the reasons, but this is not the main reason for the minimal invasive. First of all, because the tissue dissection is less, so the blood supply will reach to that area will be better, and preserving the tissue around and the blood supply also. That's why we are going to talk about particularly the calcaneum. I'm going to inform you why. So what is the anatomy and the pathoanatomy after calcaneal fracture? Particularly, I'm going to focus on the intra-articular fracture. And what is the sinus tertii approach, which is the minimal invasive approach we are going to do. And I have some studies and research about this one particularly, and what is the results, and what is the end of take-home message. So why we are focusing on calcaneal fracture? Because calcaneal fracture represents almost like 80 to 90% of the foot fracture. So it's a huge number of the cases. But not only because the majority are calcaneal fracture, because it's a high risk of disability. And it causes chronic pain, gait disturbance. At the end, sometimes the patient change the whole life because of this particular fracture. I'm not go, in details for the, sorry. So where is the pointer?
Yeah.
Okay, so this is a calcaneal fracture, and the problem, this is a 3D. It should be started in the 3D. So this is the anterior process, and we have the joint here between the cuboid. We are calling calcaneal cuboid joint, and we have this is posterior facet, and this is the lateral part, and this is a tuberosity. From the medial side, we have that groove for the tendon, and we have the syntacculum tilli. From up, we have two major joints. This is the biggest joint, the posterior facet, and we are going to talk about this particular one. Why joint? Because the disability comes because of this joint. And we have the anterior and medial facet also. The posterior facet, it's not perpendicular to the lateral wall. This is a lateral wall. You can see there is some curve here. And this one studied because the way we are going to fix with the screws, we have to know the direction very well. The blood supply, very important, because that's why we shifted to the minimal invasive or limited sinus psi approach. So we have three main blood supply: the vascular one, the lateral calcaneal artery, the lateral malleolar artery, as it's illustrated here. Before we had this large incision here. If you can see, we can tell this is like more than 10 centimeter length. And not only that, when we are doing that approach, we have to go through the whole tissue till the bone and dissecting from the bone. So imagine how, was aggressive that approach. Again, we have what's called angiosomes. This is also the same like dermatomes, but with a blood supply of the area. And this one guiding us to how to design our approaches. So calcaneal fracture, most commonly, it's because of high energy injury. And we can see even some worse than this one. It comes sometimes with open fracture. So we have to document all this stuff. Imaging, I'm not going to through the imaging. Dr. Carl can help us in that. But just to illustrate, to see how is the difference before and after the surgery. So mainly we have three main views. For foot and ankle, we have, and the hands, we have three main views should be ordered. So this is the posterior facet, as you can see. And this is the medial and anterior facet here. This we can see on the X-ray. And we have the anterior process, the calcaneocuboid joint. Okay, this is in the lateral view. What we can see, some angles guiding us for this is a normal X-ray. So if we can see the pathological or pathoanatomy of the fracture, so we can compare both. So we have this angle and that angle. Again, this is the height of the calcaneum. This is the length. And this all anatomy, in symphony, it's going to give us the cycle of the gait. Without this height and length and a particular anatomical articular joint, so we are losing all this harmony of the gait cycle. And we have axial or Harris view just to see the tuberosity here is going inward, we are calling varus, or outward, we are calling valgus. And this also will affect our gait. Broden's view, we are not usually doing. This is intraoperative. This is most commonly using intraoperative to see the subtalar joint. As is illustrated here, this we can do in certain position of the foot, so we can see the articular surface here. So this is the posterior facet. So this is the undersurface of the talus. Classification I will not go through, but we have, as long as you have that much lines of the fracture, means that the severity of the fracture is more and the prognosis is, bad. So what is the pathoanatomy? So we are going to illustrate in the X-rays, but first we have primary line of the fracture. Once we have the fractures, this fracture sometimes happen when you are falling from heights or you did sudden dorsiflexion or keeping the foot towards the body forcefully, as you did the sudden break or you fell down with the dorsiflexion of the ankle. So this is the main fracture line. Then it comes like secondary lines, this depending on the position of the foot and the momentum or the energy or injury of the, direction of the injury. So we can see like other lines of the fracture. But this one is the main one. And when we are doing reduction, so we have to focus on this particular primary line of the fracture. So when we are doing the X-ray, what is the pathoanatomy? This is a normal X-ray, but when you can see here, so this you can illustrate it, this line here. So it's one line, If you are straight at the other line here, it's another line here. So almost it's like one line. But this one should be angled up to, minimum 25 degrees. But you can see here, this because the articular surface here, sorry. The articular surface is broken and depressed down. This is a normal X-ray. As you can see here, the same. We are losing the height and we are losing the length because you can see here this one like impacted. So is that affecting our foot mechanism or the gait cycle? Yes, because you know that we in physics we studied that lever arm. So almost it will be the same because this lever arm will be shorter and the height will be, the center of the lever arm will be transferred. So the action of the Achilles tendon and the foot, the body weight will be affected, and it will be making like impingement for the ankle. It's not affecting only the subtalar joint, it affects also the ankle joint. Again, if we can see the shortening, we said we are losing the height, and there is shortening, and also will be the width of the calcaneum. And is it okay? No, it's not okay, because we have important structure here around. It will be affected, mainly the tendons. We have peroneal tendon here. It will make like impingement, and we have a small nerve here, the shoulder nerve, which is getting some neuritis, and the patient complains of the lateral aspect numb. Okay. Moreover, if you will keep this one untreated, imagine that patient will go and buy the shoes because of this width. He will buy two different sizes. For example, his shoe size is 40. He has to buy 40 and 41 or 42 to accommodate that width. Imagine. So this is most probably the pathology of the calcaneal fracture, especially when it reaches to the intra-articular parts. So why minimal invasive technique? Previously, we did that large one because in geriatric patient, we can do that small one. You know that in geriatric, we have sometimes the neuropathies, the vascular problem. So when we are cutting all this, we have many complications after. Especially the patient with peripheral neuropathy and peripheral vascular disease. In Charcot joint, if we have like fracture, we are minimizing the dissection because the healing of the skin and subcutaneous tissue will be not as normal as the normal people. And finally, we can use the same approach with the smoker. You know that nicotine is making vasoconstriction and reducing the blood supply to that area. And any healing, skin, tissue, bone, whatever, needs a huge amount of the blood supply. So with the smoking, we'll reduce the risk. And also we have a special important structure around that area, particularly the tendon, the peroneal tendon and the shoulder nerve. If we are going to cut in this way and we have that flap of approach, we might injure that one of these structures. Finally, we have these images, and we have a lot of these cases. We are calling this lateral extensile approach. And you can imagine we are cutting from here till here and till the bone, and then we are dissecting, flipping that part of the skin and the whole soft tissue, underneath. And after that, we have like wound dehiscence. Sometimes, if you can see here, sorry, the picture is not that clear, but you can see here the yellowish one. This is the plate after fixation. Exposure of the plate is, for us, it's a catastrophe. And imagine this area, we cannot do any coverage like flaps, normal coverage like skin coverage or whatever, but it will end up by this flap. So that's why we shifted to the minimal invasive techniques. So what is the sinus tarsi approach? Before it's in literature, they said we have to use that approach only for the simple fracture. And there is no difference in time, or it's not faster than the previous approach, the lateral extensile. But I do say no, because now we can use for the advanced fractures, we have like 4 types of the calcaneus fracture. They said type 2 only, no, but we can use up to type 4. And sometimes we are doing the fusion of the subtalar joint through this approach, as I will show later. And it's not faster, no, it's faster, but depending on the learning curve. As you know, when we are starting any approach or any new procedure, it needs like increasing the learning curve, so we'll be perfect in that. Instead of doing that in 3 hours, it will be like 1.5 hours. So what is the approach? It's positioning of the patient first. By the way, I started this approach in UAE, first done by me in UAE in 2016. Then I endorsed and I teach my juniors and students just to start this approach. This is the position of the patient. Then we are using tourniquet just to reduce the, it will be like bloodless field. And this is our, I'm going to publish this one. So this particular position of the C-arm, it's a new. This is as simple as this approach. This is just to marking the line, but our cut will be almost like 4 or 5 centimeters only. As you can see here, this is our approach. So from the tip of the fibula till the base of the fourth here. So this one, it's almost like 4 or 5 centimeters. Okay. They thought that this approach is very narrow to expose the joint, but in contrast, in opposite way or other way around, it's more clear than the other approach. The other approach, because you are flipping all this part here, so you cannot see clearly the articular surface. And our aim mainly to reduce anatomically the articular surface. This is our aim. Then the other issues that like length, height, all this stuff we can do indirectly because you don't want to see. So we are taking care about the peroneal tendons. It will be here. Then the Shura nerve will be here around, as long as we can see the peroneal tendon, so we can protect both of them. This is our main cornerstone that we are building up the remaining of the articular surface. This is what we call joint technique first. So we have to reduce that, the posterior facet first, even in the depressed or non-anatomical reduction. For the wall facet, it will be depressed just to see the articular surface, as I illustrated earlier. As you can see here, so this is the articular surface, and this one is depressed down. So we can see the articular surface. We reduced anatomically. We are fixing temporary with a K-wire. Then we will take the screws later. After that, we can reduce whatever you want. So this is our aim, just to reduce this posterior facet. If you can compare to the previous one, this articular surface, we have like double shadow, and now it's only one shadow here. And fix it with this screw. Then the remaining, the length, the height, the varus, the widening, all this stuff we can reduce indirectly. As you can see, we are fixing this chance with the handle just to reduce the length, the height, everything. And we have laterally here the comminution, so the medial side we are fixing temporarily with the K-wires. Then this is our final picture of the X-rays. So if you can see that the posterior facet is reduced well, the length of the calcaneum is, coming back to normal, the height still there, and also varus valgus we can adjust, accordingly. And we are fixing this screw in certain order. So the first screw will be that one, because this is the articular surface. Then we will do the medial screw, because we said this is less comminution, so it will be supporting the medial side. Then we can use the supporting screw. Usually we are not using that one as usual, more frequent, depending on your fixation. Finally, the lateral one. This is screw. This is one of the cases I did. So if you can see here, this is the articular surface. If you can see, there is a small crack in the articular surface. This is one line, and this is another line. If you can see here, the length of the calcaneum, it's shortened. The height little bit not normal, and this one is depressed down. And this is our fixation. You can see here the articular surface is okay. If you will illustrate it, that line here and here, there is an angle almost 25 degrees. We have this one we calling Gissan angle, and length, height, and you can see varus valgus, it's aligned. Before this one was facing inwards. And this is a post-operative CT. This is corrected. And you can see that articular surface already closed. And that one, that height, that the articular surface became like higher. Length is okay, and the height is okay. And this is a final wound. It's like 4 or 5 centimeters. And this is another patient, like 2 inches. So our patients, from 2016 till 2019, we did like 43. I reached now almost 100 cases with a follow-up with the CT. We are aiming to study the articular surface. We have 2 articular surfaces, the anterior process, which is articulating with the cuboid. So we have calcaneocuboid, and the posterior facets. And we have like reference. This is our cases, right or left, smoking, non-smoking, all this criteria. And this is our reference, how much is the depression and the gapping. Depending on that, we did our study. The post-op, it was immediate post-op CT. So we can see the difference. According to the reduction, proper reduction, according to the depression of the articular surface and gapping. And finally, we found that all the cases, almost like 85 to 95%, it was good to excellent. The majority was good. So to summarize that, it's a high energy injury. And we said earlier that it can change lives. We need more studies about the sinus tarsi or the limited sinus tarsi approach or minimal invasive for the calcaneum to give more recommendation for that one. Our study done according to the X-ray finding, but it's not only, the CT. It's not only CT findings, it should be function. So the next step will be scoring of the foot and the ankle scoring according to the pain, function, the patient activities, all this stuff. So this is our next step. So really we need to long-term outcome, because this approach maybe like 10 years ago they started this approach. So this is like short-term. For us, it's short-term study. So we need more study about that. And thank you.
Microphone over here, so we'll go around. We'll go around the question.
Not working. I don't know what.
Yeah, this is working. Any questions? Very technical.
When it comes to the broken bone, no questions.
So timing. So how soon should be done this surgery, and the timing, to go back to normal lives in terms of physiotherapy, touch the ground again. So
good. This is one of advantage of sinus tarsi. Before, when we are using the normal lateral extensile approach, we have to wait till some signs, which is allowing us to operate, which might take like 10 to 15 days. Then for skin wrinkling and the soft tissue will allow us to operate. But this one we can do it within a couple of days, because as I've explained, it's very small and we are not doing any dissection. The problem with the lateral extensile approach, we are doing more second trauma or second hit. Comparing to the first one, which is the original, the injury. when we are doing the surgery, so we are giving more trauma to the soft tissue. That's why we are waiting. In this approach, we are not doing any trauma. It's just simple, and we don't have to dissect that much. This is regarding when the timing of the surgery. In calcaneum fracture, usually we are waiting for 6 to 8 weeks till we make sure that bone is healed, and then he can start the rehab.
What's the youngest age you've done?
If you will see our study group, it was almost up to 60 years. 60 years, yes. From I mean, this one we cannot do in immature bone. We cannot do before 18. So from 18 till 60, we can do that approach. After that, the problem that bone quality is not good. Although we have now a new design of a special plate for the calcaneum, we can fix through that approach. So now we are shifting. I mean, the age we can do in more elderly people.
Any young people?
Sorry?
Young athletic people? Would you do it?
Young athletic means you mean younger than 80?
Yeah, younger than 60, like footballers and rugby players.
Yeah, we are doing.
But not under 60.
60, no.
Under 18.
No, because this is different. We have the entry of the screw. We have the growth plate. If we are going to insert the screw, we will distract the growth plate. So we have different approach. Thank you.
In your experience, what is the incidence of infection in these cases, and is there any stark difference between the older method and the new?
I'm talking about my study. The 100 cases we did, we faced only one case of infection. Regarding the lateral extensile approach, we have a lot. But you know that I've told you the study for the sinus dorsal or limited or MAPO technique of the calcaneum, it's a little bit limited still. We don't have the lateral extensile we were using like for a century now. So we cannot. This is unfair to compare the both of them regarding the infection. I mean, it's too early.
Dr. Khalifa, I have a question online from Dr. Salman. What about weight bearing with this approach? Is it decreased or not? And when would you start rehabilitating?
Again, the approach not for I mean reduce the timing of the weight bearing. I mean to start with bearing. The approach only to avoid the soft tissue dissection. But as a calcaneal fracture, we have to wait 6 to 8 weeks, regardless even the fixation. Sometimes we are fixing with the screws, sometimes with the minimally invasive plate. Regardless, it should be 6 to 8 weeks.
Just a quick question. I missed the beginning. Is it under GA or nerve block, or how do you operate on it?
This we can discuss with the patient, but now we can do with a nerve block. Sometimes we are doing ankle block, then we can proceed because it's only the approach will be the lateral side, so it will be easy to do under ankle block. But sometimes patient refuses. He said, "I don't want to see the operating room."
I don't see any further questions, so thank you very much.
Thank you.
Thank
you. Thank you. Thank you.
It's also fine to have some feedback, you know, the people online, so that's also
I appreciate it. Thank you.
quality and of our presentation. Thank also to the organization of Orthopaedic Surgery.
Thank you, Dr.
once
Vito
again.
and ATA for inviting me. Thank you.
Wait for your question.
It was good. Thanks.